Dear audience, in the next few minutes I would like to introduce the 3-month progress of my research about optimizing the time of cord clamping and the dosage of caffeine among preterm infants. My name is Gréta I am a first-year PhD student at the Center for Translational Medicine, and I am working at Heim National Pediatric Institute. My supervisor is Ákos Gasparics, and my scientific methodology supervisor is Mark Hernát-Fői. My vision is to improve the quality of life and extend the life expectancy of preterm infants. To achieve that, to optimize the time of cord clamping and the caffeine of the dosage of caffeine among preterms is my mission. Now let me introduce my 2 ongoing projects and specific goals. The first one is about investigating the outcomes of neonatal resuscitation with and without intact cord. According to the guidelines based on the ICOR recommendations for those preterm and term infants who do not require resuscitation at birth, delayed cord clamping is or may be reasonable. Delayed cord clamping is associated with significant neonatal benefits, such as improved transitional circulation, decreased need for blood transfusion, and lower incidence of necrotizing enterocolitis and intraventricular hemorrhage. However, most newborns breathe spontaneously after birth, but around 15% of them require some degree of active resuscitation, including airway opening maneuvers, positive pressure ventilation, intubation, or chest compressions. The need for active resuscitation is inversely related to the gestational age. So, for example, for the very preterm neonates, it is approximately 85%. Unfortunately, for these preterm and term infants who require resuscitation at birth, we have insufficient evidence on the optimal time of cord clamping. So our aim is to determine whether intact cord provides physiological, neonatal mortality and morbidity benefits for infants who require resuscitation at birth. So our clinical question is, how does starting resuscitation with intact cord change the neonatal and maternal outcomes? Investigating the population of newborns, we are comparing the interventions of starting resuscitation with intact cord to starting the resuscitation after the cord clamping. Our primary outcomes are in-hospital mortality, intraventricular hemorrhage, periventricular leukomalacia, and cerebral palsy. We have secondary outcomes as well, such as arterial blood oxygen saturation, heart rate, Apgar score, bronchopulmonary dysplasia, necrotizing enterocolitis, and so on. So we hypothesize that starting resuscitation with intact cord decreases the incidence of neonatal mortality and morbidity and increases the oxygen saturation level and heart rate at 5 and 10 minutes after birth. The clinical implication is to provide recommendation to start resuscitation with or without intact cord, and this way a decrease in neonatal mortality and morbidity. I conducted a systematic search on 19th of November with the search key that you can see here. It has 2 domains, one for the umbilical cord and one for the resuscitation. We got around 16,300 hits, and after the procedures of duplicate removal, title and abstract selection, and full text selection, currently we have 23 eligible articles. In the last couple of minutes, I would like to introduce my second project as well, which is about comparing the effects of different dosages of caffeine on neonatal morbidity and mortality. Caffeine therapy is widely used for preterm infants as it is effective in reducing apnoea of the prematurity, need for and duration of mechanical ventilation, and decreases the incidence of bronchopulmonary dysplasia. Due to the possibility of serious neurological side effects, the caffeine for apnea of prematurity shortly kept trial was conducted. They found an improvement in the rate of survival without neurodevelopmental disability in preterms who received caffeine therapy in a long-term follow-up. Of course, there are other possible side effects as well, for example, feeding intolerance, necrotizing enterocolitis, tachycardia, bloating, intraventricular hemorrhage, and so on. The commonly prescribed dose is 5 mg per kilogram per day caffeine citrate, but there is still uncertainty regarding the optimal dosage to achieve effectiveness by minimizing the potential side effects. Our aim is to compare the clinical effectiveness and side effects of different maintenance doses of caffeine therapy in preterm infants. So our clinical question is, what is the optimal maintenance dosage of caffeine citrate for extremely and very preterm infants? We are comparing different dosages of caffeine citrate, and our outcomes are neonatal mortality, morbidities, the frequency of apnea, and common side effects. We hypothesize that administration of higher dose, which means higher than the commonly used 5 mg per kilogram per day of caffeine citrate, improves survival and decreases morbidity without worsening the side effects. The clinical implication is determining the optimal dose of caffeine citrate for preterms, and this way a decrease in neonatal mortality and morbidity. In this slide, I would like to summarize my previously mentioned two projects. I would like to finish the first one next May and the second one next July. I would like to finish my presentation with my favorite quote by Ray Goforth, which is, "There are two types of people who will tell you you cannot make a difference in this world. Those who are afraid to try and those who are afraid you will succeed." Thank you for your attention.
That was a really nice presentation. I will have two questions. First, what's the definition of delayed cord clamping? And the second, if it's so beneficial, why is it a question in infants, those who require sedation? Very room. Thank you.
First, the definition of delayed cord clamping, according to the guidelines, is waiting for the cord clamping at least 30 to 60 seconds after birth. And we know it's beneficial, as I already mentioned in my presentation, but it's questionable for infants who require resuscitation after birth, because for those infants who require resuscitation after birth, the most important thing is to start the initial steps of the resuscitation. We should avoid hypothermia, asphyxia. So we can understand these are crucial, and only if we can provide these things, we can think about the benefits of the delayed cord clamping. So at so many places this is still unfeasible, but there are newly built mobile trolleys, for example LifeStart and Concord, which provides mother-side resuscitation, and that way it can be feasible.
My question would be, so as far as I know, there are two ways to administer caffeine to preterm babies, peros and intravenously. And will you consider the differences between the effects of these two ways?
Yeah. Yes, of course. Because the pharmacokinetics of these routes, the peros and the intravenous, are very different. So we are planning to have subgroups for them, and this way to see and measure the difference between them.
Okay, thank you.
Thank you for your presentation. It was really great. I have a question regarding your second project. Like some adults are caffeine insensitive and they cannot metabolize caffeine. Is that a thing in children, or do you plan to account for this in the study?
This is a very interesting question, and till now it was out of the scope of our research, but it can be very interesting, so we will think about it, and we will see in the articles how they see this.